All right, so I figured I'd start with my journey. Just like George, born in Brooklyn. I didn't know you were born in Brooklyn. But we learned very, very quickly when I got here that he was from Garden City and I grew up in this funny town called Hicksville. And, you know, when you grow up in Hicksville, everybody knows Hicksville's hip. It's the largest unincorporated village in the United States. It's where Billy Joel came from. But when you then come up to Massachusetts for college and you tell them you're from Hicksville, they're like, you grew up on a farm? You know? It's like, no. I used to live on a potato farm because that's what it used to be, but no. So anyway, I went to Clark University, and everybody in Hicksville said, what in the world is that? Why are you going there? And primary reason was they had a high acceptance rate to medical school. But when I landed there, the people I met, I felt like these are my people. I mean, I just felt comfortable. And I learned from there that every decision I have made throughout my whole life, it's not just a matter of, you know, what's the ranking and what's, you know, who says I should go there. I like to meet the people and feel comfortable because in the end, that's the most important thing. And so I keep telling my daughter, who when she was applying to college, she's like, oh, but yeah, they have a 20% acceptance rate. They're not good. I'm like, forget about that stuff. You have to be comfortable in that. So, and I think that transcends how I like to run our group, that I want to work with people who we enjoy working together with. Because in the end, the patient feels that. So then, I was eager to leave Long Island, but I knew that I really wanted to go to a state school because I didn't want to come out owing hundreds of thousands of dollars. And I was fortunate enough to be able to go to SUNY Upstate Medical University. And though not a ton of research was being done there at the time, my clinical experience was phenomenal. So when I got to residency in New York City, Mount Sinai, kind of like you were mentioning, the Harvard students, they know the book, and the Tufts students, they know the patient. I started out at the Bronx VA on my first rotation in the CCU. That was the very first day. Met my first AIDS patient back then, and this was back in 1990. So it was 1990. And people's IVs would fall out. Well, we were in the VA. We didn't have IV teams. So who did they call to put in the IVs? It was me. So I was out there like, I'll put this one in. And really, we had a lot of exposure to patients, a lot of responsibilities. People were watching us. And so that's where I kind of learned my love of actually taking care of patients. I'm very interested in the academic aspects of things and research, but being together with the patient is number one for me. So went to Mount Sinai, figured I would try New York again. And while I was there for just those 3 years, my apartment got burglarized. And one weekend I had my car, I lived on East 95th Street. I had my car 2 blocks away with the club on it, if you remember what the club was. Was gonna go visit my girlfriend for the weekend, go up to upstate New York, and where'd my car go? And went to the police station, they said, it's probably on a boat to Ecuador or Belize. And that's when I said, okay, I am done with New York. I gave it a shot, sorry. So I then came back to Massachusetts because I really loved New England. And I picked New England Medical Center because of some of my mentors in medical school who had done their residency and fellowships there. And I was primarily interested in hematology. I really loved coagulation, and that's what I thought I wanted to be. I loved looking at under the microscope at pathology, and got there, did my research in clotting disorders. And while I was there, the GI oncologist left and they said, Larry, do you mind like helping out in the GI Cancer Center? I said, no, sure, why not? And then a few months later, the thoracic oncologist left. They said, Larry, do you mind helping the surgeon, Ben Daly, who's a very senior surgeon and one of the best physicians I've ever met? Can you come in and work with Ben because he just kicked out the other guy? And I said, sure, I'll do that. So I then stayed there for after fellowship for 7 years, and I did thoracic oncology, GI oncology, and ran the hemophilia center and coagulation disorders. And then in 2003, I started, actually for a few years, I was getting called by MGH. Say, why don't you come over here and look at a job? And I'm like, I'm not going to the dark side. At Tufts, we all love each other here, and we care about patients. We're not thinking about research, and I figured I wouldn't be happy anywhere else. And so eventually I realized that I wanted to step up my game, potentially be more academic. And it was such a great decision going to MGH. And they said I have to give up thoracic and I have to give up all the hematology. And so I focused on GI. And I thought they were going to help me develop a research program. And I had a few clinical trials, and I was very collaborative with a lot of people. But what they really need is they need help seeing patients. And so some of my colleagues yeah, you want to see this patient on the floor? I'm like, oh, absolutely. And so I got the reputation of never saying no. And within a few months, I was already pretty much the go-to guy for GI oncology at MGH and loved it and got to know so many people throughout the system. And then was able to, just through taking care of patients and collaboration, and that's one of the things I love about what I do. You can't do GI oncology without collaborating with people like Larry, sharing patients and radiologists, everything. I'll have a slide on that. But then I was asked to be the director of the infusion center, which is like a 65 chair infusion center at MGH, and then ultimately the clinical director of the GI Cancer Center. And we had, I think, 9 or 10 of us GI oncologists, and it was great. I love the people I work with there. And so in 2016, there was a decision to have Mass General take over the cancer program at Newton-Wellesley. And I didn't mention this, but many, many years prior, when I was still at Tufts, one of the members of the practice, actually a couple of members of the practice at Newton-Wellesley, used to send me their coagulation patients because coagulation is like a hot potato. You don't want, it's like liability. And I loved that when I was over at Tufts. And so I took care of those patients. And they're like, oh, could you cover us on the weekend? So I actually covered that practice for quite a number of years. And I still remember going out to dinner with Jeff Wish and Tim O'Connor, and like, we are in the premier practice. Why don't you join us? And I was like, wow, pretty tempting. But, I really loved the academic practice that I was in at the time. So during my moonlighting, I got a taste of what Newton-Wellesley was. And I knew it wasn't just a private practice or a community hospital. It was really an academic, I felt like a kind of a unique hybrid type situation. And meanwhile, I moved to Needham, so I'm passing there on the way to work. And I'm like, I can't leave Boston until 8 o'clock, otherwise I'm going to sit in an hour of traffic. And I'm like, what if I went to Newton-Wellesley? I could be home in 10 minutes. And I think Larry probably had something to do with me coming out. And I know there was a bunch of back and forth about things, but I said, I will come out if I can recreate MGH at Newton-Wellesley. By that, I mean the best of MGH at Newton-Wellesley. People who know me and people who know people who I take care of, I get very involved with my patients, and that's what I set the standard in my clinic. And I didn't want to change that. I was able to do that at MGH. I wanted to do it at Newton-Wellesley. And but I wanted everybody to be subspecialized. I was not going to go back to being a generalist. And they said, okay, you could do that. And that's what we developed. And I think we've developed an amazing program in our cancer center on many levels. I mean, I guess another thing, looking at it, when you're at a place like Newton-Wellesley, I know things were in a certain way for a long time. And here you have kind of big old MGH coming, and what are they going to do? Are they going to take over? And I think Larry knew by working with me, I'm very collaborative and very passionate about what I do. And I thought the culture at Newton-Wellesley was great, and I didn't want to change that. But I thought that there were things that can be changed to improve the management of our cancer patients. And I like to have the latest and access to the best. So as part of the Cancer Center, we don't only take care of cancer, we take care of hematology. It's critically important for our hospital to have a good hematology service. And in hematology, we often talk about benign hematology. The new name for it is classical hematology. And those are things like anemia, bleeding, clotting disorders, iron issues, and something called myeloproliferative disorders where you have very high red counts or very high platelet counts. And then there's a true malignant hematology that we all know of: leukemia, lymphoma, multiple myeloma, and myelodysplastic syndromes. Oncology, I'm sure everybody in this room in some way is touched by cancer. We know somebody who had cancer or passed away from cancer, or maybe have cancer or had cancer. In the United States this year, there'll be about 1.9 million new cases of cancer diagnosed, over 600,000 deaths. And in the Commonwealth, there'll be 42,000 plus new cases, almost 43,000 new cases, and over 12,000 deaths. Now, I chose to specialize in GI oncology, and unfortunately, the outcomes for many people with GI oncology is not as great in some of the areas. And for example, colon cancer is the fourth most common cancer, but it's the second leading cause of cancer-related deaths. Pancreas cancer, which you could see on here, is kind of down on the bottom in terms of incidence, but is the number 3 cause of cancer-related deaths in men and women. So it is a lot of what I do. It's not just having the best drug to treat the patient, of course, that's a no-brainer, but it's being able to care for our patients who get ill with our treatment and get ill because of the disease. And so we take care of the patient. It doesn't matter if they're getting chemotherapy, and many of our patients choose not to get chemotherapy. And that's where we need the help of some of our other services to care for these patients. Colorectal cancer, because it's what I do. We have a good news, bad news story. Good news, decreasing in incidence in older patients. Bad news, increasing in younger patients. And recently, recommendation was made to start screening patients at 45. I wouldn't be surprised in a few years if we say maybe it's 40. And in this slide, where the bigger figure here, this is the current situation. This is 2015 to 2019. As you get older, you're more likely to find you have a higher incidence of colon cancer within that population. If you take out the age from 50 to 59, you could see from 50, 51, and 52, the incidence in green is higher than in red, meaning compared to 1975 to 1979, the incidence is higher. In all the ages above that, the incidence is going down. There are probably a number of factors to explain that. It's probably related primarily to environmental factors to some degree. And we've noticed that it's people who were born around 1950 and after, that's where we're seeing a higher incidence in the younger population. So, prevention is also very important, not just treating the patients. And so we need to get the word out to have people screen, get their colonoscopies at an earlier age. Unfortunately, we're also diagnosing people at a later stage, and some of that could be due to the younger population. When people are young, they feel, okay, I can't get this cancer. You go to the primary care office, and they're not thinking about a 30-year-old having colon cancer because the incidence is so low. But we have to think about that because we are missing some of these patients. And so local disease, percentage of local disease is going down. Those with regional, meaning lymph node involvement, is going up, and metastatic or distant disease is also going up. So I'm happy to be part of the Mass General Cancer Center group or system. There are a number of hospitals that are part of the Mass General Cancer Center, and there are different kind of levels of affiliation. We're all connected in one way. But again, based on our subspecialty nature at Newton-Wellesley, our size, and the fact that we have extraordinary hospital where we can handle a whole lot in our center, we are part of what is called the Quad in our program. And that consists of the main hospital, Mass General, the Mass General Cancer Center in Danvers, and then the Mass General Cancer Center in Waltham, or MGH West, which is right off of 128. And so two of my colleagues who are part of our program are also medical directors at two of these other centers, in Danvers and in Waltham, and they both have clinics in our place. And both of them want to desperately hold on to their Newton-Wellesley clinics because they love being there. The academic mission, the teaching mission, it's a different feel in our office and in some of these other places. And the purpose of this, the great thing about being part of this quad and being part of the network, is that everybody in our clinic, all the docs, have to be connected with a specific disease group in Boston. So if you're a lung cancer doctor, you must be connected to the lung cancer team at MGH, attend all of their meetings, present patients there. And this way you get to know all the docs there, all the surgeons. And so, they send patients out this way, we send patients out there. The other good thing about this is that our colleagues at Waltham, oftentimes their cancer center, infusion center is crowded. They can't fit people in. Well, we say, come on over, send them over to Newton-Wellesley. What if we have a problem with our pharmacy, which has happened every once in a while? Things happen, refrigerators go down or something happens. Leaks. It's an old building. We get leaks with some frequency. So what happens is we then bring everybody together and we bring a meeting right away and we help divert people to other places. And so this has been incredibly helpful. We help MGH, they help us. And we're all friends and it works very well together. Oncology is like a team sport, as I was alluding to before, and that's why I love oncology and I love GI oncology, because I can't do what I do without the help of other great people. Diagnostic radiology cannot be overestimated. It is so, so important. When I was at MGH and I would see second opinions from all over the state or New England or over the country, so much of our difference in opinion was because we were able to review the scan with a high-quality radiologist who would pick out things. If I would see a pancreas cancer patient, I don't know how many they did in a community hospital in, I don't want to pick any state, but in a small community hospital, maybe they would see 10 pancreas cancers a year. Well, I'd have a clinic at MGH, and I would see in a typical afternoon 5 or 6 new pancreas cancers. And so when you're seeing that kind of volume and you're seeing all the unusual things, the radiologists pick up on things. So having diagnostic radiology that is high quality, and not only there, but there to look at the scans with us. And I put in a big plug because we almost were at risk of losing the radiologists that we have. We would still have radiologists, but we work so well with our radiologists from Mass General, and I'm going to fight to have those radiologists stay with us because they make us look good. Interventional radiology, those are the folks who put in the ports and do procedures, who work in George's vascular center. Pathologists, also critically important. If you have pathologists who are not good at making the diagnosis, you look bad and you're doing the wrong treatment for the patient. We have wonderful pathologists. One of our GI pathologists reads cases at Mass General. The chief of pathology reads cases at Brigham and Women's. So our folks are really connected to state-of-the-art diagnostics. Our hospitalists, already mentioned, they're phenomenal. They communicate well with us. They take great care of our patients. Our patients from MGH, because we have a lot of overflow, they want to send patients to us, they just rave about the care that they get, and so then they don't want to go back into Boston. They don't want to wait in the ED, and then they don't want to be on the floors there. They really like it at Newton-Wellesley. Cardiology. George and I have been talking ever since I came here. I was talking to George. I think I bugged him when I first came here. I said, I need a cardio-oncologist. I have one at MGH. I want one here. And he's like, whoa. We could help take care of this. We'll work with our guys in Boston. We could do that. And the team there has been really great in helping us. And we've had some complications related to chemotherapy, which are rare, but they happen. And they've been great, and they work very well with the people who do only cardio-oncology in Boston, and so that the patients don't have to keep going back and forth. Gastroenterology, needless to say, Larry is an important ally, and we have great endoscopists. And we do a lot of really complex procedures at Newton-Wellesley. But there are some things that we can't do here. And our gastroenterologists know what they can and cannot do. And we then make a decision together. Okay, this patient should go in and get this advanced procedure. And part of it is that we want to make sure if there's a complication that we have the appropriate backup. We don't want to be left in trouble. But there's very little that we have to send into Boston for endoscopy. Of course, endocrinology, I do a lot of pancreas cancer. They have diabetes. They have all other kinds of issues. Infectious disease, pulmonary, dermatology, a lot of the new drugs, immunotherapies, they all have dermatologic toxicities. I send rashes, and it's great. I call any number of dermatologists, and I tell them I have this problem. They're like, send them over now. I almost never get told, we have an appointment in 3 weeks from now. So that's great. Rheumatology, again, my immunotherapy drugs, they now cause all kinds of rheumatologic problems. And Bob Friday, who's the chief of rheumatology, is always great about getting these people in right away. And nutrition. And I'm sure I missed some here. Again, we can't do what we do well without having a hospital full of other resources. Multidisciplinary clinics. This is one of the things that is critically important. And something that I learned as a fellow at Tufts, and Tufts was really good about having multidisciplinary clinics, meaning if you get a diagnosis, let's say of a colon cancer or rectal cancer, you will meet a medical oncologist, a radiation oncologist, and a colorectal surgeon at the exact same time. There are other big academic medical centers in Boston where you will meet the medical oncologist. You'll get an appointment the next day to meet the radiation oncologist, and then another day you'll meet the surgical oncologist. They may or may not have talked about you beforehand. In our clinics, in GI at least, and in the others, we sit together, we review the scans with a pathologist, with a radiologist, the whole team, the gastroenterologist, and we go in there already with a plan when we meet the patient. We've already looked through the chart. That's usually the medical oncologist who does that leg work. But we go in there together and we walk out all the questions answered. And patients love that. And that is something that's unique, that does not happen in many, or I think most, community practices. So what's my philosophy? Providers must be subspecialized and affiliated with the disease center at Mass General Cancer Center in Boston and attend subspecialty conferences. New patients should have access to the multidisciplinary care, which I really think makes a huge difference in the outcomes. All patients should have access to clinical trials. We're unable to have a huge portfolio of clinical trials, and I'll have another slide where I'll talk a little bit about that. But because of our collaboration with Mass General and because we attend all the conferences, we should be offering what we have in Boston to them and not say, well, we're just going to keep them at Newton-Wellesley. Many of them don't want to go into Boston, but we need to let them know what the options are, be perfectly, completely transparent. All patients with advanced cancer should have access to palliative care. When I first came, we had no palliative care in the outpatient. And I was starting to wonder whether or not I made the right decision to come out. I am so dependent on palliative care, so dependent. They are so important. Quality of life and just, I think even in survival, they make the patients live longer because of their interventions. And so fortunately now we have palliative care every single day in our clinic. And even if they're booked, if I have an urgent situation, they will come down. And I have many visits that I do together with the palliative care nurse practitioner or attending right there, 2 attendings in the room with the patient and the family, and it's very powerful. All patients should have access to behavioral health resources, social work. We have 2 social workers in the cancer center. Psychologists, we have our own clinical psychologist, and the PAC program, which is parenting in challenging times. So a lot of our people are young, they have children, and even grandchildren can be affected by this diagnosis. And these are child psychologists who then speak to the parents or grandparents on how to communicate with their children. And provide academic medical center care in a warm community environment. That is important. And I think most of our patients feel that way. I think they do feel that they're getting a special kind of care. and they're feeling like we're on top of their situation. This is our team, and I left out people. I left out all of our nurse practitioners, so please don't tell them I left them out, because our APPs are phenomenal. But here we have the solid tumor folks, and half of these people are anchors at Newton-Wellesley, but we have Mass General oncologists who also come to supplement what we do. We have a head and neck oncologist who does a multidisciplinary clinic with head and neck surgeons and radiation oncologists. We have a melanoma. One of the melanoma folks comes out here, also does a multidisciplinary clinic. One of our lung cancer docs in town, who is a national authority on lung cancer and early detection, who comes out and does a clinic once a week at the cancer center. And we also have a neuro-oncologist who sees brain tumors and complications, neurologic complications of cancer and chemotherapy. And then we have our hematologic group that see either benign or malignant hematology, as I mentioned before. This is an area that we're trying to beef up. There's so much need for hematology, and there's so few hematologists out there, so we're actively trying to expand that. We have a bunch of surgeons we work with. We've got breast cancer surgeons. The breast cancer surgeons only do breast cancer. We have a hepatobiliary pancreas surgeon from Boston who comes and sees patients every Friday. He spends all morning, and sometimes it goes into the afternoon, and we all see patients together. On Thursday, we have colorectal multidisciplinary clinic. And so we have 2 colorectal surgeons that are phenomenal. I mean, word on the street has it at Boston, at MGH, you're somebody who wants to see the best person, you come out to Newton-Wellesley and get your surgery there. We have the state-of-the-art robots, and patients get the care. They get very, good attention from all of us. So I think I am so happy to have people. These are all good people. These are all people who are dedicated to the patients and also have a passion for research. So I really have a great team. I'm really lucky. We also have a neurosurgeon that comes out, not necessarily based, or you could see clinic. He does attend clinic, but it would be remotely. And we also have urologic surgeons, and we have a multidisciplinary GU cancer program with a medical oncologist, radiation oncologist, and surgeon. So, for all the major things, there are only like 1 or 2 areas that are very uncommon that we don't have, and that we would send people into Boston for that consultation. And if they want to then get the treatment at Newton-Wellesley, we would then potentially give them the treatment and work collaboratively with our colleagues. We've had a tremendous amount of growth in the cancer center. It's a very busy slide. We don't need to go over the details, but if you look at the bottom, the 5-year change, 111%. It's very clear we have grown. I think not only have we grown, and I think my colleagues could attest to the fact that we've also taken care of more complicated patients. And there may have been a time where truly complicated patients were felt to be better managed in town, and it's very uncommon that we send patients into town to get treatment. I mean, obviously, we don't have an ego. If we think the best place for them to be is in Boston, absolutely. But most of the time, the patients don't want to go. They want to stay. And so you could also see in this graph here how we've increased to over 1,400 new cancer diagnoses. And it's not any one person. It's everybody. It's having the surgeons. It's having medical oncology, radiation oncology. This is just showing that our volume for all of our cancer services is gradually increasing. There's ups and downs. And we do really well with our what's called a Net Promoter Score. So these are surveys that many of you probably have received at home after you come back from a visit, and you wonder, does anybody look at these things? Do they really care? We care tremendously about this. I get a report every week, and I look at it, and I'm looking at the trends, and I'm looking at the comments that people write. I look at every single one of them for our group, and we share a lot of the comments with the entire division. So we send an email out saying and if we see something that's not so good, we then talk to the people to whom those have been, that it's directed at. And this has been good for the people in our group to see when people say nice things. I think they feel good. It's a really hard job for the people who do the checkout and everywhere, infusion, to hear the positive feedback is really very nice. So what are our accomplishments? We've grown. And, my colleague Dave Ryan in Boston always says, you can't be stagnant. You always have to grow. And if you don't think about growing, you will fall behind. So I always want to expand what we offer and always want to increase. And so I think we've been very successful. Despite, there's been staffing challenges. I mean, COVID was difficult and it is hard to retain certain kinds of support staff, but we're doing okay. We have excellent patient experience scores, integration of our providers with the MGH Cancer Center disease leaders, and most of them do feel like they're integrated into the Boston program. We've opened, Larry mentioned before, opened up a second linear accelerator so we could treat more patients. Beforehand, we had very old machine that kept breaking down. And so we've replaced that and added a new one. And not only can we treat more patients, we can now do some of the more complex treatments that take more time on the machine, something we called SBRT or radiosurgery. That's doing surgery with very focused radiation. Our people were certainly capable of doing it, but we couldn't take that much time off of the machine. Now we have two machines, so we could do a ton. Challenges. Clinical trials programs is at risk due to funding. Unfortunately, clinical trials is a money loser. Nobody makes money on clinical trials, but it is critically important to the mission. And when you have really good medical oncologists who are academically oriented and trying to advance the field, we love putting people on clinical trials. We want to contribute. And patients, I think, often like to participate in clinical trials. So we'll have to see. But when people ask me, well, where could we use help? One of the areas I say is clinical trials. And I'm really passionate about that. Increasing amount of effort devoted to prior authorizations and appeals. I think we're all feeling this in the system. Everything gets denied. You then have to appeal. It's lots of time on the phone. Half of the time it might be a misunderstanding. Oh, you should have said that in the first place. It's like, well, that's 5 phone calls later. And so it takes a lot of time. It takes time away from taking care of the patients. And I think that's about it.